Thank you, Hani. Thank you for having me today. We're going to move up from gross surgeries into micro biology and biochemistry. So things you're not going to be able to see, we're going to talk about. I'm talking about the autologous ortho biologics and their use for diabetic foot ulcer. We are dealing with chronic wounds. Most of our time treating diabetic foot ulcers, we're treating the chronic wounds. And these wounds are defined that a wound that's not healing after 3 months, but nobody waits until that time, and then we say this is a chronic wound. We have a better criteria. If the wound is not dropping in size, like half of its size within 2 to 4 weeks, then this is a chronic wound. And here we want to do something else to start or push the wound into healing. We all know that the healing process of any wound starts with the hemostasis, inflammation, tissue formation, and then later on tissue remodeling. It seems that the chronic wounds, it's got trapped or stuck into the inflammatory phase. This inflammatory phase typically takes about 7 days, and then after that you can see that the microbiology and the biochemistry of the wound bed has changed, the pH has changed, and the type of enzymes and cells within the wound bed is different than the other acute wounds. That's what we say. We always want to try or convert the chronic wound into an acute wound in order to move on with healing. In my lecture, I'm going to be covering some orthobiologics that are derived from the human body. We're going to be talking about the PRP, PRF, bone marrow aspirate, bone marrow aspirate concentrated, and the adipose tissue. So the autologous orthobiologics has been introduced in the treatment of different musculoskeletal disorders, skin and bone. Some of them can be used with antibiotics, some of not. Some of them are, and in this lecture I'm only talking about the autologous ones, so the ones that are coming from the human body. And the materials within these are the cytokines, mesenchymal stem cells. We want to do some emphasis on the stem cells because these are the ones that they're the magic things. They have the ability of differentiating into specific cells. They can provide signals for other cells to come and get recruited into the wound bed to start the regeneration process. And also it can alter the inflammation in the wound bed and push it more into the second or the phase afterwards. First, we're talking about the products coming from the peripheral blood. Here we're talking about the platelet-rich plasma and the platelet-rich fibrin. The PRP is typically a concentrated form that can be taken from the blood, put it in the centrifuge machine, and then injected back into the body or around the wound that is not healing. It's rich in growth factors, cytokines, lysosomes, and it's responsible for reinitiating and restoring the pathways of healing. The platelet-rich fibrin or the leukocyte with fibrin, it's a different one, same, taken from the blood platelet, but it's a different process. And it has a leukocyte component in it, so it can work into treating the infected areas. And the main difference actually between both of these products that the PRP, it releases a great amount of growth factors, but in a short period, so it can give you a kickstart for the wound, while the PRF, it works, but for its lifespan up to 10 days of releasing growth factors into the wound. As I said that the PRF, we like it more than the PRP because it's malleable, it's strong, you can use it as a skin graft, you can cut it around and put it on the wound and give it some time until you achieve healing. It has an immune stimulating or an immune enhancer in form of leukocytes that can help in treating osteomyelitis after surgeries. There are some very good clinical trials, randomized clinical trials, comparing the PRF versus a control group, where the healing rate was about double. After that, we talk about products that are coming from the bone. And the difference here, the main difference between them and the one coming from the blood, is the presence of mesenchymal stem cells. So the bone marrow is the primary site for mesenchymal stem cells. It's really strong, and as I said, it works by directly differentiation into a loss cells and by recruiting other treating or other cells into the wound bed. So it can be locally applied, it can be injected into the wounds, into the wound bed, typically harvested from the iliac crest. It has a big amount of tissue. Some people take it from the tibia and calcaneus, but still the iliac crest is a better place to get it from. You can take it, apply it immediately without processing, or you can process it, put it in the centrifuge, and in that form you're going to be getting a concentrated one that has more of mesenchymal stem cells. Well, the studies in healing wounds using the bone marrow aspirate is not that much. It works better into healing bone, so we don't use it much into healing only chronic wounds. The last one that's coming from the human body are the mesenchymal stem cells coming from the fat tissue. In the past, or typically, the fat tissue, their graft they're taking and use for contour defects and aesthetic and reconstructive surgery, but there are recent studies that shows that it has more regenerative capacity. So now we're using it in treating wounds, and it's way stronger and better than bone marrow aspirate in terms of having more stem cells. It's about 2,500 folds, as you see here. This is a diagram showing you the difference between the three different main groups of orthobiologics that's coming from the human body, from the peripheral blood. I don't have a laser pointer here, but the peripheral blood, you have the PRP, PRF. You can see that it does not have mesenchymal stem cells, but it's really rich in platelets, really rich in leukocytes, fibrin, growth factor. When you go to the bone marrow aspirate, it does have the mesenchymal stem cells, so this has a better healing capacity than the platelet-rich plasma, but we don't have much studies out of it. Then the last one is the adipose tissue, where you can use it to fill up a defect or to enhance healing better than the one before it. As we said, it has much more mesenchymal stem cells in it. So at the end, we are treating complex wounds that have difficult pathogenesis behind it. The wounds have systemic and local issues other than the wound bed. There is limitation in conventional treatment treating these wounds. That's why we have to move on with more innovative interventions. So much potentials, but we don't have much studies. Insurance don't cover it most of the time. Very rare insurance that cover these orthobiologics. That's why patients don't like them if they have to pay for them. Very expensive, but they do show some promise. Thank you.